Okay, I'm going to start. Hello, everyone. Sorry. Hello, everyone. Assalamu alaikum. I am Raushanara, nursing instructor from Gajipur, welcoming you in webinar of introductory course in palliative care for humanitarian health worker batch 3. Today is 2nd of July 2021, session 6. Discussing topic is management of other symptoms, nausea, vomiting, dyspnea in palliative care. Will be discussed by the learned faculty Zillian Fals and Fatima Lada. Zillian is a palliative care physician from British Columbia, Canada. Fatima is a clinical pharmacology specialist on oncology and palliative care from Canada. Fatima will focus on the pharmacological part, especially in the pediatric issues. So we have case presentations from Dr. Hunter. At the end, the complete summary will be done by the Lailatul Firdaus. Before starting, I am softly recalling you some Zoom etiquette. Please make sure that you are on mute unless speaking. Use chat for the question and discussion, either Bangla or English version. So now I would like to invite you, our first speaker, Jillian Files, for deducting discussion. Jillian, over to you. Thank you.
Thanks, Roshan. Saeed, if we can get these slides up, please. So I hope that everybody's had a chance to look at the video where Fatima and I talked about nausea and vomiting in detail and breathlessness in detail. What we're going to just do is review quickly and then get all of your questions and comments. So while we're waiting for the slides, the key thing with nausea and vomiting is to assess. Okay, you need to assess carefully in the ways that we've already discussed. You need to do a good history and physical, and do investigations only if this will change your management. Because what you're trying to determine is what's causing the nausea and vomiting. You able to do the slide, Saeed? Or do you want me to share my screen?
Said, are you here?
Yeah, I'm here.
Okay, please, thank you.
Okay, so the common causes of nausea and vomiting, there's a list in palliative care, include medications. If patients are on opioids, the tramadol or morphine, absolutely this can cause nausea and vomiting, certainly in the first few days, and you need to warn patients about that. Saeed, do you want me to share my screen, or are you having trouble with getting the slides up?
I don't have your slide. So
you don't have them. Okay. Okay, I'm going to share my screen.
It will be convenient.
Are you seeing the slides?
Yes.
Yeah, it's fine.
Yes, we see them.
Can you start the?
Okay, so you can see the slide.
Can you start the slide show?
I can't understand what you're saying, Saeed, and I can't look at.
You can go to the left corner of the slide, upper part of the left corner of the slide, and slide show. The play button.
Sorry, I'm not getting that. So
I think he's just suggesting you put it on full screen or slideshow version.
Oh, I haven't done that. Okay. How's that?
Perfect.
Okay.
It's nice. Thank you.
Okay, so let's carry on. So nausea and vomiting are common in the palliative setting. Medications are common causes. Opioids, NSAIDs, like drugs like ibuprofen, antibiotics, over-the-counter or alternative or complementary preparations can sometimes cause nausea and vomiting. Metabolic causes, particularly in the cancer setting, high calcium, liver, kidney disease, and certainly gastrointestinal causes. So gastric stasis, which is when the stomach gets kind of baggy, and that can occur with illness and with opioid medications, ulcers, bowel obstructions, severe constipation. Central nervous systems with brain involvement can also occur, not so common, and vestibular causes, so the inner ear causes, can occur. They're not are the commonest causes. And often nausea and vomiting is a combination of the above. So you need to think through all of these causes. What is causing the nausea will lead you to the neurotransmitter that's responsible, and that will lead you to the medication. Okay, so as I mentioned, you need to assess carefully and only investigate if it's going to change your management. So management, as with all the other symptoms, well, not all the other symptoms, but certainly breathlessness that we're going to talk about in delirium, correct the underlying cause if possible, okay, and if it's appropriate. So if the person's got high calcium and it's appropriate to treat, you may wish to do so. Adjust other medications. If you can get rid of some of the medications that may be causing nausea, get rid of those. If you think it's the opioids, and if it's possible to use adjuvants, so as Dr. Catherine talked about previously, some of the other medications that can be useful for pain that aren't opioids, and reduce the dose of the opioid, that might help. If people have constant nausea, you need to regularly administer the antiemetics, not SOS. Select the route. If somebody's vomiting a lot, giving them medication by mouth is not going to be effective. So you need to think about whether you can give it subcutaneously under the skin, rectally. You need to prevent and treat constipation. And if possible, control the environmental factors that might be contributing. Bad odors, try cool, damp cloths, easy things that can help people with nausea. So the classes, I'm going to hand this over now to Fatima to talk about classes of anti-nauseants. And I'll advance the slides as you wish, Fatima.
Thanks, Jillian. All right, so just to reiterate, when we're looking at classes of anti-nauseants, your choices will depend on what you determine to be the cause of the nausea. So as Jillian mentioned, you have to think about the different neurotransmitters involved. Most of the time, we will end up using the class of medications called antidopaminergic. So I will focus on these for the next few slides. Next slide, please, Jillian. So the first of these drugs, just to double check, make sure you watch the video specifically for pediatric dosing and to understand more of the background around this. But just as a brief synopsis. I'm sorry? Okay.
I think you can go ahead. It might have been a mistake.
Okay, sounds good. Okay, so metoclopramide, also known as Perinorm, for the brand name you might be familiar with. We usually go with 10 milligrams 4 times a day, and that can be given oral, sub-Q, IV. The key facts about this particular drug, it's centrally acting on the dopamine receptors and on serotonin receptors to antagonize them. It also has peripheral activity as a prokinetic, which is why we can use it when you know someone has, say, constipation or there's gastric stasis. It'll help move things along, which, as we know, constipation and stasis can contribute to nausea sensation. Very important as a factor with that is to avoid it in bowel obstruction, because there is an increased risk of perforation of the bowel. So that's something to assess prior to starting metoclopramide for any patient. Because of its activity on dopamine, it does carry a risk of extrapyramidal symptoms. So please be aware of that when you're using the dosing in your patients. And that also ties in with why we must dose reduce in renal dysfunction. Please take a look at the recording for further details. Next slide, please. Another antidopaminergic is domperidone. That's usually given 10 milligrams up to 3 times a day, maximum of 30 milligrams in a 24-hour period. Similar to metoclopramide, it does antagonize dopamine type 2 receptors, but more in the periphery. So it will not cross the blood-brain barrier. Therefore, its overall carries less risk for extrapyramidal symptoms. An added caveat with this drug is QTC prolongation. So if you know you have a patient who has a history of arrhythmias, is on any other medications with QTC prolongation risk factors, please be aware of that before starting domperidone. And once again, it is renally cleared from the body, so it does require dose adjustment in renal dysfunction. And again, that information is within the recording. Next slide, please. Another one that's commonly used is haloperidol, anywhere from 0.5 to 1 milligram. orally or by subcutaneous route, and we can give this twice a day up to 3 times a day. Similar to metoclopramide, it's a centrally acting antidopaminergic drug. It's a good choice for nausea and bowel obstruction because it does not have that prokinetic mechanism that we would be worried about causing any sort of perforation or anything. However, similar to domperidone, it does have an increased risk of QTc prolongation. Therefore, we want to avoid it in patients with heart arrhythmias if possible. Other alternatives would include prochlorperazine, levomipramazine, and olanzapine. These drugs are much more broad spectrum. They target multiple drug receptors, and therefore they also have multiple adverse effects to be aware of. They're generally reserved for second line, usually in scenarios where you're not quite sure what is the cause of the nausea. And they can also be used quite a bit for anxiety-related nausea. Olanzapine in particular is now being used more frequently in the oncology setting because we know it's one of those few drugs that actually has evidence for use in prevention of nausea, whereas all the other medications have evidence for prevention and treatment of emesis. So that's something to factor in as well. Okay. Next slide, please. Okay, Jillian, non-pharmacological measures?
Yep. Okay, thanks, Fatima. So Fatima concentrated on the antidopaminergic medications, the classes, that class, because that's the one that we like the best. There are, as you know from the video, other classes, the anticholinergics, antiserotonergics, and antihistamines. So some of those drugs include ones like the antihistamines are dimenhydrinate, cyclizine. Antiserotonins are palinositron, ondansetron. You may have seen some of those. These drugs are useful in specific situations, and we talk about that in the video. So what about non-drug management? So diet modifications can be very helpful. We talk about that in more detail. Taste changes can really affect people's quality of life, certainly. In different areas of the world, there are different complementary treatments and alternative for management of nausea and vomiting. And in North America, ginger and peppermint can be found to be helpful. In Nepal, it's lemon tea. In Andhra Pradesh in India, it's lime pickle. And we're told that in Bangladesh, cardamom is used to reduce nausea and vomiting. Okay, so that's nausea and vomiting. That's the overview. We're going to move on to dyspnea or breathlessness in palliative care. And as we talked about in the video, about 50% of people referred for palliative care have dyspnea, shortness of breath. We're generally bad at treating this. Palliative care professionals aren't so good at treating dyspnea. So we really need to be attentive towards that. So 60 to 70% of lung cancer patients present with dyspnea. Certainly it's more common in the last weeks of life, but it can occur even if you don't have lung involvement. And we'll talk about that with regard to causes. So the common causes of breathlessness in palliative care, obviously cancer and tumor involvement of lung tissue and or airways, pneumonias, COPD, congestive heart failure, pulmonary emboli can also cause shortness of breath. Doesn't have to be cancer related. If you become cachectic, very weak, your respiratory muscles can get weak and that can contribute. Ascites, so fluid in the belly, distending the belly, pushing up on the diaphragm can contribute and cause dyspnea. As well, low hemoglobin and anxiety can make, certainly can make it worse, and it can go along with dyspnea and be quite severe. So you're going to assess carefully history and physical. You're going to do appropriate investigations, and as with nausea and vomiting, treat the underlying cause if possible. So if you can tap the ascites, if it's appropriate to treat the low hemoglobin, if it's appropriate to treat with antibiotics, you're going to do all of those things. Then we're going to go quickly through the other ways to treat, the general ones, drugs, oxygen, and the others. So general measures, position. You've all seen people leaning over. That can be helpful with the dyspnea for babies and children, position of choice, the position that the child gets into may well be the one that's least uncomfortable for them. Fans and open windows can be very helpful. Air over the face, maintaining local COVID rules, of course. And there's good evidence for techniques like breathing retraining, pursed lip breathing, relaxation techniques, as well as advising the patient and the family about priority setting, determining what's important for them, saving their breath and energy for what's important. If possible, avoid stuffy rooms. I know that's difficult. Play therapy can be useful for children and babies as well. So drugs, opioids. Opioids are very effective for breathlessness and palliative care, both in the malignant cancer and non-cancer setting. But you're going to start at a lower dose than for pain. And Dr. Catherine talked to you about morphine and tramadol doses earlier in these sessions. There's clear evidence for its use. If people have constant breathlessness, you're going to use it routine. If not, you can use it SOS. Morphine is first-line treatment, and you start with half the pain starting dose, so 2.5 to 5 POQ4 and SOS. If all you have is tramadol, that certainly can be used as well. Other useful medications, depending on the cause, steroids, so dexamethasone, prednisone, but dexamethasone is our favorite. Give it once daily in the morning. It can be good for severe vena cava obstruction, bronchial obstruction, and there's other causes I mentioned. And benzodiazepines, or perhaps other drugs for anxiety, as Fatima mentioned, can be useful for severe anxiety. If you're starting somebody on an opioid, you need to be careful about if you're going to start them on a benzodiazepine at the same time, because the person can get very sleepy. So do take care using these medications together. That is that. I am going to stop sharing my screen. There we go. Back over to you, Roshan.
Yeah, thank you so much, Jillian and Fatima, both of you, for your wonderful reviewing on the management of nausea, vomiting, and dyspnea in palliative care. Now we have a discussion session, question answering. Megan, question polling, as I know.
So let's get some discussion and then maybe do the polling questions then.
Yeah.
Oop, here they are. Okay, never mind.
Sorry, I was just pulling them up. There you go.
That's okay. That's great. Can everybody see the polls?
So go ahead and answer. You have to answer all 7 questions, I think, and then we can discuss them. Sorry, I don't know how to do it one by one.
It's okay. And everybody can see them, I hope?
Yes, we can see them.
স্ক্রিনে যে পোলটি দেখা যাচ্ছে, আপনারা সবাই এখানে 7টা প্রশ্ন রয়েছে, সবগুলো প্রশ্নের উত্তর দিবেন, তারপর আমরা ডিসকাশনে চলে যাব। ধন্যবাদ।
Good. We're starting to see the answers. I'm seeing that people are completing the poll, so that's great.
And you'll share those when they're ready.
Yeah, like I'll just give it
Yeah.
a couple more minutes because there's a lot of questions to go through.
Yeah. Yeah, so there's 7 questions if people can do their best. And we'll go through the answers and have some discussion, hopefully.
Yeah.
Okay, so just another couple of minutes. Let's see if we'll go through them. Okay, thanks, Megan. Okay, so we can see number one, if constant nausea is present, it is better to give antinausea regularly rather than SOS. That is true, so that's great. Almost everybody got that. Number two, approximately what percentage of patients starting on opioids will experience nausea at least short term? That was kind of a mean question because we only talked about that in the video, but half got it right. So it is 30% of patients will experience nausea short term starting an opioid. So that's what you need to counsel patients about. And Dr. Catherine, I think, talked about that. And you may need to use an anti-nauseant up front for the first couple of days, and you certainly should counsel patients about it. Okay. Diet modifications can be helpful in the management of nausea. Absolutely true. Almost everybody got that. Thank you. Number four, opioids can be very helpful in the management of nausea in the palliative setting. True, 90%, yay. I'm scrolling down. I hope everybody else can see those as I'm scrolling down. For patients with complete bowel obstruction, haloperidol is a good choice for nausea management. That is true. So let's just review that quickly. So metoclopramide is our favorite, except for in the situation where somebody has a complete bowel obstruction. So if that's the case, haloperidol is a really good choice for that. So think about that. Haloperidol, if that's all you have, is a good choice for nausea overall, but particularly in the situation of complete bowel obstruction. Okay, number six, which is the best starting dose for morphine in a patient with dyspnea? 2.5 POQ4H or 5 Q4-PRN? Yeah, 2.5 POQ4H for somebody who's got constant dyspnea is a good start. You could make it PRN if they don't have constant nausea. It's certainly saying it should not be used for dyspnea is not correct. Opioids are very effective for people in the palliative setting with severe dyspnea. The last one is tramadol can be used to manage dyspnea if morphine is unavailable. True, yep, almost everybody got that. So that's great. So perhaps some of the things to spend a little bit more time on are management of bowel obstruction and just reviewing use of opioids. Thank you very much. So back over, Roshan, to you for discussion.
Thank you so much. Yeah, thank you so much, Gillian. Yeah, may it very helpful and effective for the participants, I think. Yeah, do you have any questions, dear participants? If you have questions, you can unmute yourself and can do the questions. Anyone? Any questions or any queries? Yeah, Gillian, there is one question regarding the number 7 question. Yeah, could you explain more?
Yes, I just remind myself what the number 7 question is. It's tramadol can be used to manage dyspnea if morphine is unavailable. Well, tramadol is another opioid. Morphine is the drug of choice for the use of dyspnea in palliative care, but you can also use tramadol. Dr. Catherine talked about tramadol at some length and Spatima in the pain presentation. So you can use that drug, but you would use it at a lower dose, or perhaps half the dose that you would use for morphine. Okay. I think
Yeah.
tramadol is more available to you than in Bangladesh than morphine is, or at least in some
Yeah.
settings.
Yeah, you are
Yes.
right.
So I'll just add to that. So when we're thinking of using tramadol, it is not the best choice because if you recall from the sessions that Catherine and I presented, tramadol relies on the metabolism of converting tramadol to its active metabolite that is morphine-like using the CYP2D6 enzyme. Now, there's variations in the activity of that particular enzyme. Therefore, there will be variations in how well someone is able to convert to the M1 metabolite. So tramadol can work if you do not have morphine available. Of course, morphine is still the best option, but certainly tramadol can be tried to see if it will help with managing dyspnea.
I hope that answers your question. I have a question. How available is metoclopramide in your settings? We know from an overview that Fatima did last year that it's available to some, not all. In MSF, you have it? Okay, Tasneem, I'll answer that. So in MSF, you have it. Anybody else who?
You?
Roshan?
Yeah. কেউ কি একটু বলবেন যে আমাদের এমএসএফ বা আমাদের যে সেটিংস সেখানে ট্রামাডল কতটা অ্যাভেলেবল? বাংলা, ইংলিশ? Yeah, please.
Hello. So in MSF we do have metoclopramide, so we use it a lot. But I have one question, and that is that I'm not sure that if we can use the same preparation for subcutaneous use, because we do it for IV, but I'm not very used to with subcutaneous route still now. So thank you.
Yes, you use this. Yes, thank you for that. The subcutaneous route is very, very helpful. And yes, you use the IV preparation, you give it sub-Q. I don't know about the dilutions, how you do that, but absolutely, metoclopramide sub-Q you can use. There is a question from Tasneem.
Yeah.
I don't know if that's to me but I'll answer it. Do we need to stop morphine if it induces vomiting? Maybe to the participants. So the short answer to that is no. Morphine and other opioids can cause nausea in about 30% of people when you start, but it tends to get better. Okay? It's not like constipation, which does not get better the longer you're on the opioid. But morphine nausea does tend to get better after 3 to 5 days. If somebody has a history of nausea and vomiting, or has nausea and vomiting previously with medications, then you may want to start somebody on metoclopramide or low-dose haloperidol, SOS, when you start the opioid. Oh, there's a question from Rachel.
Another question is there. Could you explain the Fatima regarding this one? About tramadol for dyspnea, we tried it once in a young child with the chronic heart disease, 6 months of old, because we had nothing else at the time. I didn't seem to have much effect, but I was not sure how if we could increase the doses. Fatima, could you explain?
Yeah, sure. So it depends on what dosing was used. As you remember, with 100 milligrams of tramadol is approximately equivalent to 10 milligrams of morphine orally. So it really does depend. If it did not work, part of the reason might be the child is not able to metabolize because they're lacking the ability of the CYP2D6 enzyme itself. So in that particular child's case, I would say it's probably best to try and access morphine if you can, if that's the appropriate drug of choice for the child as well.
Megan, do you want to add anything? Sorry,
Yeah,
do you,
Megan, for dosing around tramadol in
or one of the other
pediatrics, because
pediatric
that's, yeah.
palliative care specialists?
I don't see Megan on the call anymore. Sorry.
Oh, okay. So that's too bad. You weren't sure about the metabolism, clearly, so I didn't know if it was safe to escalate. Okay. Any other feedback, situations where you had trouble managing nausea before we go on to the case?
Any more questions or confusion?
We recently had a case in Kenya where it was really difficult to explain to the family about the nausea and vomiting because the cause of it was the bowel obstruction. I'm not sure if people are also facing that in Bangladesh. We had a very, very long team meeting about it. Just trying to work backwards, like the cause of the nausea was the most distressing thing, but the cause of it was the obstruction, which we were not able to manage well because her disease was so advanced. So yeah, it was hard to fully explain. I don't know if you guys have experience with that, or can give pointers on how to kind of explain when the cascade is so long in that sense, to help families through that.
So are you asking about
When bowel obstruction is the cause of the nausea, and there are limited things that we were able to do for the bowel obstruction, how to support the family.
Okay, so what do people think about that? How would you, so we're not talking about medications, we're not talking about whether you would use
yeah, we did the NG
and the whole thing. Okay.
Yeah, we did the NG2 to alleviate it, but it was really challenging for the family.
Okay, so the question is medication to the side, because I'm sure you tried everything. How would people support the family with the child? Vomiting, NG tube in, terrible thing.
Yeah.
What are some things that you can do? Either stick up your hand or put it in the chat. Oh no, that wasn't. How do you counsel families of young children who have severe symptoms? What are some of the things that you could advise the family to do? You could do the cold cloths. You could do distraction, play therapy, that kind of thing.
Yeah.
What else can you try? Okay, so Erin, what did you try? What did you do?
Yeah, we tried, we discussed at length kind of the disease process, and that her cancer was quite advanced. So although they were in the process of trying to even get a second opinion, because the things that we were saying were not really, in their sense, like justifiable things to do in the situation. So we tried to work with them. We said at this point she was so frail and so sick, we didn't really advise them to go to another hospital because she was feeling so unwell. And I think she actually did pass away 2 days later. But we were trying to just really explain to them what was going on, that yeah, with the NG, we were trying to kind of reduce the escalating situation of what had been happening to her. And we were really trying to encourage them to spend as much time with her as they could. You know, if there were other people that wanted to visit at that time, it was really challenging though, because I think they felt that we should have removed the obstruction. But it obviously wasn't that easy. She wasn't a surgical candidate. So yeah, it was really distressing. She was 17, actually. She was pretty young.
Yeah, it's very difficult, isn't it? When families say, why can't you just cut it out? And that's a really good question. But often it isn't possible. And it sounds like you use maximal doses of the medications and haloperidol and everything else that you had. Terribly difficult. Okay. Any other
Thank you.
comments, ideas?
Hmm.
Sorry, Roshan.
Any other, yeah, any other comments or discussions? If not, we want to move to our case discussions. So I am privileged to introduce with Dr. Hunter Gronginger. Dr. Hunter is a director of Palliative Care, MedStar Washington Hospital Center, Washington, D.C., USA. Welcome and over to Dr. Hunter.
Thank you very much. Can you all hear me okay?
Yeah.
Looking for a sign.
fine.
Okay, great. Good morning or good evening to everyone. It is wonderful to be back here today to share a case with you that is based off of the presentations that you have seen on the video this week and we just talked about now. I'm going to share my screen, I hope. Can you see my screen with slides? Great. And I'm going to go to the beginning of that.
You just need to go.
Super.
Yeah.
So this is a case presentation, and I know that it can be challenging to interact through Zoom the way that we are all around the world. But through the case, I have specific points where I would really love for participants to contribute your thoughts about this case management. And you can do that either by raising your hand, and I can try to identify that and call on you, or speak up, or enter it into the chat, whatever is easy for you. Okay, here we go. So this is the case of a 57-year-old man with chronic obstructive pulmonary disease, or COPD, and he also has hypertension and diabetes. He lives in Dhaka with his wife and his two sons. They are ages 12 and 14. He used to work as a construction laborer, but he has not been able to work for several months because his COPD has been getting much worse. So you're able to visit him at home. And I'm interested initially to think about what main symptoms he may be experiencing and what are the questions that you would ask about his symptoms. So I will pause there and see if any of the participants have any thoughts about assessing his symptoms. Oops. What are some questions that you want to ask?
আপনারা কেউ শেয়ার করেন প্লিজ, যে কি ধরনের উপসর্গ থাকতে পারে অথবা কি কোশ্চেন করা উচিত এই পেশেন্টকে অ্যাসেস করার জন্য। বাংলায়ও করতে পারবেন, ইংরেজিতে করতে পারবেন, হ্যান্ড রেজ করতে পারেন, আনমিউট করে আপনি কথাও বলতে পারেন। Anyone?
Okay, so someone writes to ask about respiratory distress.
Yes,
Absolutely, absolutely. With COPD, that's something that is concerning to us, and it's clearly affecting his physical condition, his function, right? He's not able to work. Oh, I see some wonderful things coming in the chat. This is great.
Yeah, yes.
So about the symptom time course, the duration, how severe is it? Are there associated symptoms with the respiratory distress? For example, fever that might be signaling a pneumonia. Dr. Jillian had talked about pneumonia as an additional source of dyspnea in our patients. Are there other complications with the hypertension, with the diabetes that are going on right now. Maybe that would signal perhaps an infection. Can he complete a sentence in one breath? That's a great question. So is it difficult to move around or to be active? Is it also difficult to talk or difficult to eat? Those are questions that I'm often asking people. Any relationship to using medication? Have you been able to use your medications? Maybe you ran out of medications. That's a fantastic question to be asking, because we're thinking about all the resources that having a serious illness can involve. And someone early on, I'm looking back to the some of the initial chats, people asked about available medications and then any stress related to financial issues. Absolutely. Here's someone who may be the primary, the primary breadwinner, the person who is providing for his wife and 2 sons, and he's not able to work now. What is that like for the family? These are great questions. Thank you all very much. So these are some fantastic questions about his symptoms. And I think maybe in summary, to try to summarize a little bit, I hear two big things I'll focus on for this slide. One is perhaps the primary symptom of interest is dyspnea or breathlessness. And we want to know a history of that symptom. Is it acutely worse, chronically worse? What affects it in terms of activity? What makes it better? Medications or otherwise? Any of the non-pharmacologic interventions? Dr. Jillian talked about breathing exercises, pursed lip breathing, a fan, and so on. And then the second thing that I'll emphasize, I really, really like how you all are also thinking about the bigger picture. Is this impacting his family life? Is this creating anxiety? Are there other symptoms associated with this? What's the impact on his wife and children? Because we think about the whole family in palliative care. Awesome. So I will continue the case. So he reports dyspnea and fatigue and anxiety. His dyspnea he rates at 4 out of 10 when he's totally resting and 8 out of 10 with activity. So it's present, perhaps moderate when he's totally resting, and it gets to what we might think of as severe dyspnea with activity. His fatigue he rates as 4 out of 10. His anxiety is 2 out of 10, mild, except sometimes at night it increases to 6 out of 10. You asked about what helps with the dyspnea, and he says the bronchodilator medications help. Airflow helps if there are open windows or a small fan, or oxygen can be helpful. So what might be your next steps? Here's more of a history about his dyspnea specifically. What might be your next steps in managing his dyspnea? I'll give everyone some time. So there's one question I see in the chat. Is there any anxiety related problem? You know, that's a great question, and there certainly might be. You see that he has some anxiety most of the time, and it seems to get worse at night. Sometimes that makes me wonder about, what happens at night that's different from the daytime. Maybe it's a time when he's just thinking about what's going on and worrying about his situation. And we also know that anxiety goes very closely with dyspnea. It's important to manage breathlessness, and that will often improve some of the anxiety related to that. So I see some medical workup questions. Should we do a chest x-ray to check for an effusion? Possibly. Pulmonary function tests or an ECG or an x-ray? Possibly. These are all things that might help us target better the underlying source of the dyspnea, although, from a palliative perspective, visiting a patient at home with a known history of COPD, it might be just as reasonable to start focusing on his symptom management immediately maybe while we're at the same time planning some of these tests that might be more complicated to do, might not be something we can do right away. Depending on the patient's goals, depending on the patient's resources, whether or not we're able to do some more sophisticated testing. I see that from Aaron, the dyspnea seems to be getting worse with activity. Could an as-needed medication help that he could use before the activity? Thank you, Aaron. That's a great question. So we've talked a little bit today, certainly in the video during the week, and then today, Fatima and Jillian were talking about medication use that might be helpful in dyspnea. Anything come to mind that we might consider a trial of? So I see bronchodilator with a mild dose of steroid. Certainly possible. Thinking about managing the COPD, taking medications regularly, that's also good. All right, I'm going to jump ahead just in the interest of time. So hopefully this is helping to reinforce some of the things that we've talked about this week, and especially today. Management of dyspnea, the first thing is to try to conceptualize what is the disease, the underlying disease that's contributing to the dyspnea. So in this case, it seems to be the COPD, and we might think about how do we manage this source of dyspnea. It might be different management from, say, dyspnea from a malignancy. Someone mentioned, perhaps there's a pleural effusion, or from congestive heart failure. Perhaps the patient would have pulmonary edema and benefit from a better diuretic regimen. But in this case, if we're really focusing on the COPD, we might think about supplemental oxygen when that's appropriate. Cautious use in COPD, of course. Airflow, like we've talked about today. And then I want to underline symptom-directed therapies, right? So we talked a little bit today about opioids for dyspnea. And some people in the chat recommended considering them initially as needed, perhaps given in advance of activity. If the dyspnea gets worse with activity, maybe a small dose of an opioid might be helpful a little bit prior to activity. For patients who have dyspnea all the time, around the clock, perhaps they need scheduled opioids. And then what are some of the things, if we were to try an opioid here, either morphine, which we talked about, or tramadol, which we've talked about, what are some things that you might explain to the patient about the opioid and side effects? We've just had some good multiple choice questions about opioids and side effects. What are some important side effects to tell patients about if we are prescribing an opioid? So we talked about, I heard Dr. Jillian talking about constipation, and opioids are known for causing constipation. As she mentioned, constipation is a side effect that patients typically do not develop a tolerance to. They just stay constipated. And if people are taking opioids, sometimes just as needed, certainly if they're taking it regularly, it is important to include a plan for the constipation, like a laxative. And we just talked about how up to 30% of patients who are initiated on opioid therapies may develop nausea initially. In most cases, the nausea gets better after a few days of using the opioid, but sometimes we need a nausea medication available as well to treat that nausea due to the opioid initiation. Good. And I think that I will finish here. So here's an example of what a successful strategy might be for this patient. So if it's available, this patient may benefit from low dose oxygen therapy given the COPD, continuing bronchodilators, and assuring the patient has ongoing access to those medications, as many of you mentioned, encouraging fan use. Again, there's just something wonderful and mysterious about airflow over the face that really seems to help with the subjective sensation of dyspnea. Dr. Jillian had mentioned a low dose morphine as something to try. 2.5 milligrams by mouth every 4 hours as needed. That would be a really reasonable starting dose. And then the last point that I'll make, just because I think it's helpful to ground our discussions in clinical research. You don't need to know this last bullet point, but just to share with you that even now people are really trying to understand the best ways to use opioids for breathlessness in COPD and doing clinical trials to understand this better. And I think that really helps us when we are practicing palliative medicine and explaining our medication recommendations to patients and families, and also to other clinicians, why we think this will be really helpful, that we are developing evidence behind these recommendations at the same time. So I will stop there. I want to be sure if there are questions or comments to end with. I think everyone's done a really nice job of thinking about understanding the underlying mechanism of the dyspnea. That's really important. Using available tools in our toolbox to manage this symptom acutely and chronically to the best of our ability, preferring to do it in the patient's home environment whenever that's possible. And I really like how you all are thinking also about the impact of this chronic progressive illness on the patient and on the family. And I see this final comment, counseling about social and spiritual issues may be helpful for this patient. Absolutely. He has a disease that is worsening that will impact his life and therefore impact the life of the people around him. So that's part of what we do in good palliative medicine. I will stop there and turn it back over to you, Rosa.
Yeah. Thank you so much, Dr. Hunter, for that interesting case. There are many challenges points you have raised. Do you have any questions to clarify the cases? Dear participant, if you have a question, please ask. Any more questions? If not, may I request Irin Das to add something, especially in social or spiritual issues or nursing issues?
Yeah, I was just actually thinking, these patients that we see, so my context would be more in Dhaka, but of course our participants for this course are in often in more rural settings or not in large cities. I'm wondering how we support these patients with chronic diseases when oftentimes they most likely are not being seen by another primary doctor. So I would assume many of the patients that we see in our clinics or in our home-based care, we actually might become their primary doctors dealing with issues like COPD. So I think it's a really interesting case that Dr. Hunter has brought before us today, because sometimes we can see these patients as not really our patients. There should be someone else that should be looking after them because, they might not be at this moment end of life. But in palliative care, what we try to do is we try to support families and these patients through the journey of their chronic illness. So that's why this situation is really important. And especially with the recommendation of starting low dose morphine, which in palliative care, we do have more experience with, we can have confidence to treat these types of patients well. So I think if you are facing situations like this and you're seeing people in your clinic with these kind of chronic issues, I would really encourage you to become and feel confident to become one of their primary caregivers, medical caregivers. because I think in palliative care, we can really offer a lot to these families. Just from the chat, really, I'm so impressed by the different ways that you guys have thought of how we could take care of this patient. And it really gives us a lot of encouragement, I think, as faculty, to see that it's going on in your mind as you think of this case. So hopefully you can put that into practice this week as you go back to your clinics and as you are seeing patients like this.
Thank you so much, Irene. Tasnim Apu. Tasnim Apu, are you here? Maybe
I don't see her on the list anymore, so she might have dropped off.
Maybe. Okay. Anyone? Captain?
Thank you, Roshan. Can you hear me okay? Is the sound okay?
It's
Yes.
fine.
Great. So I just want to encourage, because I know some of you do not have access to morphine. I'm not sure if any of you have access to morphine, but I want to encourage you to think about the patients that you're seeing. Think about how many patients are breathless, how many patients are in pain, and more than think about it, maybe start collecting the data to say we've got many severe COPD patients that are breathless, we've got many patients in pain, and just start using that as a tool to try to push to get your organizations to start advocating for access to morphine. Because everyone's busy on the ground, and sometimes you're busy seeing your patients, and we're doing lots of things that we can do. But if you see there's a gap, and we know there's a gap in symptom control, I just encourage you to do that little bit extra of charting it and using any data you can collect on it to try to make the difference, because we know there is morphine in Bangladesh. We know that FKRF and IOM do have access to morphine for some of their patients. I know it's not easy, but there will be people in your organization who do advocate to improve care, to improve healthcare. And so become a part of that. And by becoming a part of that, we can improve the care for the patient in front of you. Okay, maybe not this patient right now, but hopefully moving forward for the next patients that are going to present with breathlessness. So I just want to encourage you to make that a part of your work, to try to make a difference to those of you who do not have access to morphine right now.
Yeah. Thank you, Captain. Any other faculty? Would you like to add something?
It's Jillian. I just want to support what Dr. Catherine just said. I think anybody who's felt severe shortness of breath, how terrifying that is. Just think about how awful that would be to live with that day in and day out. It's scary for everybody, terrifying for the family. And there are things that we can do, as we've discussed.
Great. Thank you. Any more? If not, I'm going to request Lailatul Firdaus for doing Bangla translation. Lailatul Firdaus is a palliative care nurse from Center for Palliative Care. Lailatul?
Thank you, Roshan. Can you hear me?
Yeah, we are fine with you.
Thank you. আমি আজকে আপনাদের সাথে বাংলায় একটু বলতে চাচ্ছি যে কি নিয়ে আলোচনা হলো। তো আজকে আমরা বমি বমি ভাব এবং বমি এবং শ্বাসকষ্ট নিয়ে একটা আলোচনা হয়েছে, এবং কি এখানে আমরা দেখতে পাচ্ছি যে বমি বমি ভাব এবং বমি এটা খুবই কমন প্যালিয়েটিভ কেয়ারে। আমরা সাধারণত 50% রোগীর ক্ষেত্রে আমরা এটা দেখে থাকি। এটা বিভিন্ন কারণে হয়। দেখা যায় যে বিভিন্ন ঔষধ যেমন ওপিওয়েড কিংবা এনএসএআইডি অ্যান্টিবায়োটিক এগুলোর কারণে হতে পারে। বিভিন্ন ধরনের পেটের অন্যান্য যদি কোনো বাউল অবস্ট্রাকশন থাকে সেক্ষেত্রে হতে পারে, এবং কি আরো কিছু কারণেও হতে পারে। এটার ব্যবস্থাপনার ক্ষেত্রে যেটা বলা হয়েছে যে কারণে করা হচ্ছে এটাকে আসলে হচ্ছে ঠিক করতে হবে আগে, তারপর হচ্ছে ওষুধ দিতে হবে সে অনুযায়ী। যদি হচ্ছে যখন বমি হচ্ছে তখন ওষুধ দিয়ে যদি কাজ না হয় তাহলে সবসময় যদি আরো ওনার বমি থাকে তাহলে সবসময়ের জন্য কন্টিনিউয়াসলি একটা হচ্ছে বমির ওষুধ চালিয়ে যেতে হবে। আর খেয়াল করতে হবে যাতে পেশেন্টের কোষ্ঠকাঠিন্য হয়ে না যায়, সেটা অনেক সময় কোষ্ঠকাঠিন্য হওয়ার কারণেও কিন্তু বমি ভাবটা হতে পারে। আরো কিছু কাজ আমরা করতে পারি, যেমন ওনাকে হচ্ছে যদি আশেপাশে কোথাও দুর্গন্ধ থাকে কিংবা একটা পেশেন্টের হচ্ছে ক্ষত থাকে সেখান থেকে হচ্ছে উনি এই বমি ভাবটা আসতে পারে, সেজন্য আশেপাশে দুর্গন্ধ দূর করা কিংবা একটা ঠান্ডা কোনো কিছু দিয়ে মুখটা মুছে দেওয়া, এগুলো হচ্ছে আমরা করতে পারি। কিছু ওষুধের মাধ্যমে হচ্ছে কমানো যায়, এগুলো নিয়ে আলোচনা হয়েছে। এগুলোর মধ্যে মেটোক্লোপ্রোমাইড নিয়ে আলোচনা হয়েছে। এটা আমাদেরকে বলা হয়েছে যে বায়োল অবস্ট্রাকশন এর ক্ষেত্রে যাতে এটা ব্যবহার আমরা না করি। আর বায়োল অবস্ট্রাকশন যদি থাকে সেই ক্ষেত্রে হ্যালোপেরিডল হচ্ছে একটা ভালো একটা ঔষধ। তো এগুলার কিছু কোথায় ব্যবহার করা যাবে, কোথায় ব্যবহার করা যাবে না এগুলো দেওয়া আছে। আপনারা হচ্ছে এগুলো দেখে নিতে পারেন। তবে এই ওষুধের পাশাপাশি কিছু ওষুধ ছাড়া কিছু চিকিৎসা আছে। যেমন হচ্ছে খাবারটা একটু হচ্ছে ঠিকঠাক করার মাধ্যমে যে রোগী যেটা খেতে চান, যেটা খেতে ওনার ভালো লাগে সেভাবে আমরা তৈরি করে দিতে পারি। ওনার মুখের যে স্বাদটা এটা হচ্ছে একটু বাড়ানোর জন্য আমরা কিছু ওষুধ, হার্বাল কিছু ওষুধ আমরা ব্যবহার করতে পারি। আমাদের দেশে যেমন এলাচ খায় অনেকে, কিংবা আরো বিভিন্ন দেশে যেমন লেবু চা খায়, তারপর হচ্ছে আদা খায়। তো এগুলোর মাধ্যমে কিন্তু আসলে ওই বমির সময় আমরা সাহায্য করতে পারি ওষুধ ছাড়াও। তারপর দ্বিতীয় যে বিষয়টা নিয়ে আলোচনা হচ্ছে সেটি হয়েছে যে শ্বাসকষ্ট। প্যালিয়েটিভ কেয়ারে শ্বাসকষ্ট খুবই কমন, দেখা যায় যে 50% রোগীর প্যালিয়েটিভ কেয়ারে শ্বাসকষ্ট হয় এবং 60 থেকে 70% রোগীর লাং ক্যান্সারের ক্ষেত্রে শ্বাসকষ্ট হয়ে থাকে। জীবনের শেষ পর্যায়ে এটা খুবই হচ্ছে কমন একটা বিষয়। এই শ্বাসকষ্টেরও কিছু কারণ আছে, যেমন যদি ফুসফুসে কোনো টিউমার থাকে কিংবা কোনো ইনফেকশন হয় কিংবা শ্বাস প্রশ্বাসে আমাদের যে শ্বাসতন্ত্র এটার অন্য কোনো প্রদাহের কারণে, এগুলোর কারণেও হতে পারে। কেউ যদি খুব বেশি দুশ্চিন্তা করে ক্যান্সারের রোগী, সেক্ষেত্রে শ্বাসকষ্ট হতে পারে। এটার ঠিক ব্যবস্থাপনার ক্ষেত্রেও বলা হয়েছে যে আপনাকে হচ্ছে আগে যে কারণটাতে হচ্ছে সে কারণটাকে আসলে আমাদের চিকিৎসা করতে হবে জেনারেল ট্রিটমেন্ট দিয়ে, তারপর হচ্ছে ওষুধপত্র দিয়েও চিকিৎসা করা যাবে। পাশাপাশি যদি কোনো রোগীর অক্সিজেনের প্রয়োজন হয় শুধুমাত্র সেই ক্ষেত্রেই অক্সিজেন দিতে হবে, অন্য ক্ষেত্রে এটা হচ্ছে দেওয়ার প্রয়োজন নেই। এটা আসলে মেপে নিয়ে তারপরে আমাদের দেওয়ার চেষ্টা করতে হবে। তারপর এখানে অন্যান্য অবস্থায় বলা হচ্ছে যে রোগীর অবস্থানটাকে, পজিশনটাকে যাতে আমরা হচ্ছে ঠিক করে দিই। একটু যদি রোগীকে উঠে বসানো যায় কিংবা উনি বসতে পারে, কিংবা একটা হচ্ছে সামনে টেবিল দিয়ে যদি দুই হাতটাকে যদি সামনে উনি একটু উপর হয়ে থাকতে পারে তাহলে কিন্তু শ্বাসকষ্ট একটু কম হবে। মুখের সামনে যদি আমরা কোনো ছোট ফ্যান দিয়ে রাখতে পারি কিংবা ওই ভিড় গুলো আমরা সরিয়ে দিয়ে জানালাগুলো খুলে দিতে পারি, একটু ঠান্ডা বাতাস যদি হচ্ছে আমরা হচ্ছে প্রোভাইড করতে পারি ওই জায়গায়, তাহলে কিন্তু রোগের একটু উপকার হয়। কিছু এক্সারসাইজ আমরা করাতে পারি, যেমন শ্বাসের একটা ব্যায়াম, ব্রিদিং এক্সারসাইজ, তারপর হচ্ছে কিছু শিথিলায়নের কিছু টেকনিক আছে, মেডিটেশন এই ক্ষেত্রে হচ্ছে হেল্প করতে পারে, এগুলো আমরা করতে পারি। আর রোগীর যাতে রুমে যাতে খুব ভালো একটা বাতাস চলাচলের ব্যবস্থা থাকে এটা আমরা খেয়াল করব। তবে শিশুদের ক্ষেত্রে মনে করতে হবে খেলাধুলার মাধ্যমে ওদের কিন্তু হচ্ছে এই পজিশনের ব্যাপারটা হচ্ছে কিন্তু ওরা নিজেরাই ঠিক করে নেয় যে কোন বিষয়টা আসলে ওদের ভালো লাগছে। আর ওষুধপত্রের ক্ষেত্রে শ্বাসকষ্টের ক্ষেত্রে বলা হয়েছে যে ওপিওয়েড জাতীয় ওষুধ আমরা হচ্ছে দিতে পারি, কম ডোজে শুরু করতে হবে এখানে, এবং কি ব্যথার জন্য যে ডোজটাতে শুরু করা হয় তার থেকে কিন্তু অর্ধেক ডোজে এটা শুরু করতে হবে হয়েছে। এবং স্টেরয়েড কিংবা হচ্ছে ডাইজিপাম জাতীয় ওষুধ আমরা এক্ষেত্রে ব্যবহার করতে পারি। এরপর আমাদের হচ্ছে একটা কেস নিয়ে আলোচনা হলো, এটা নিয়েও আপনারা সবাই পার্টিসিপেট করলেন। তো ধন্যবাদ। এই ছিল আমার বাংলা সামারি। থ্যাংক ইউ রওশন আপা।
Thank you so much. You are great. It was wonderful translation and Bangla summary. Yeah. Thank you especially to Jillian, Fatima, and Dr. Hunter. And special thanks to all the participants for your active participations. So we are very close to our today's sessions. Here are some session announcement. Our next sessions will be 9th of July, 2021 at the same time. And topic of the discussions will be the communication and how to manage communications with PPE. And those who are joined late today, there will be the video sessions, so you can watch this one before starting joining of the next sessions. So we will share the video and key learning points very short. Thank you so much and stay safe. Thank you. Thank you, everybody.
Thank you.
Thanks, Roshan. Thanks, everyone.
Thank you.
Have a great week.
See you next week.
Don't know bad.
Bye.